welcome everybody to today's webinar session. My name is Anita Hayes and I'm an associate working with Hospice UK and working with the Emergency Care Hospital Improvement Programme. What I'd like to do for the next 20 minutes or so is to take forward a session really talking about moving from learning to action, and also to give some thought to preparation for our next face-to-face event on the 20th of June. So really what I'm going to be doing is talking about preparation and also talking about recapping on some of the learning that we had on a previous session when we started to talk about developing driver diagrams. So we can just move on to the next slide. And really what I would also like to start by doing is to thanking all of you and all of your teams for making us very welcome as we've been coming to visit you in your hospital trusts. And also thank you very much as well for your honesty in terms of sharing with us both your challenges and your opportunities. And I think as a team, you know, we've been very, we've been very impressed, and we've been able to see the great work that's happening across the community of practice. And importantly, your team's commitment to take that to the next step in terms of improvements in focusing in urgent and emergency care and improving end-of-life care. And again, having those conversations very openly and honestly about the challenges and about how we might take forward those improvements. So we just wanted to say a big thank you. And we also know that as well, you've been very focused on developing thinking about your case file reviews and developing the start of your improvement plans. And again, you know, we understand that people are at various stages with those improvement plans. So today, what we wanted to just give some thought to, as I said, is to think about why driver diagrams are particularly useful to us in our improvement work, to think about how you would go about developing a driver diagram in practice, to think about the relationship, because we talk about the model for improvement, we talk about PDSA, but you know, how do these things relate? We want to share a short video with you, and again, this is a video from the Institute for Healthcare Improvement. Some of you may already have seen this, but it's a really good summary. We'll also give you some other signposts to other really useful resources. And I think also today to note that there is a new publication coming out from NHS Improvement today, very focused on measurement, which is a really important aspect of all of the work we're talking about. So we'll signpost you to that resource as we go through the presentation. Okay, so we just go to the next slide. Okay, so why use driver diagrams? Well, I think if we think about a driver diagram, really what, you know, that is doing is it's helping us to put on a single page, you know, what our really what our theory of change is. More importantly, I think what that driver diagram does is it helps us as a team to start thinking about where in the system we want to work, and it helps us to structure that complexity. You know, we spent some time, didn't we, a couple of sessions ago, thinking about the complex systems in which we're working and thinking about all those interdependencies. And the driver diagram is a really good way to identify that complexity on a single page and simplify that so that we all can, you know, work together. It also brings the team together. You know, actually developing this driver diagram is very much a team activity, and it should be so, because, you know, we do all see things from different perspectives. And I think, you know, trying to start to be clear about where in the system we want to make change happen is crucially important. It then supports our improvement activities, and it works together. Hello? Hello, I think is that Faye joining us again? Okay, so, you know, so this driver diagram helps us to structure complexity, helps us to think about what we're aiming to do on a single page. It really brings us together as a team to start to translate our learning into action, and it really supports the work that we're doing going forwards, and in particular to consider how we're going to measure if the changes we make are an improvement. On to the next slide, please. Okay, so just to say, we're not going to give you a single template per se. We know that there are many driver diagram templates out there. You may already be familiar with and using a trust template, a driver diagram that's within your trust improvement teams, and that is absolutely fine. Equally, some of you may prefer to use the Excel template, which is on the NHS Improvement Hub, and again, very easily accessible, easy to download. And if some of you prefer to work in Excel, then absolutely that is there for you. As we're just talking through this session, what we would say is that we would aim for consistency, and we have a template which we will share with you, and obviously you're able to use that template. But equally, if you're using other templates, then the consistency we're really seeking to maintain, if you like, with whatever template you're using, however you're deciding to develop your driver diagram, is to have that overall project aim, to have those primary and secondary drivers, and we'll come on to that, to have your change ideas, and importantly to have your measurement. So to have all of those elements as key components of your driver diagram. So this first slide is really talking about your overall aim or project goal. And again, what you're seeing here is really just, again, good practice highlighted on many websites. I haven't reinvented a wheel. This is the advice you'll find. But really what I wanted to highlight with this slide is you will come across as well different terminology. You will see it written as overall aim, you will see it written as overall project goal. So just think that this is, that first step in the improvement, model for improvement about, what is your overall aim, what are you trying to accomplish, and that is what we're talking about here. And I think just those tips here about ensuring that you've got that involvement with your patients in your overall team, thinking about what it is your improvement project is aimed at doing, and thinking about it in that terms, because ultimately everything we're focused on here is about improving that quality and experience and care for patients, service users, families. It says customers on there. I think I changed that earlier on, but again, some people use this slightly odd language, but it's the people we are serving, we are aiming to make this difference to. That first key question in the improvement model. Using available data. So now you do have lots of data, lots of information available to you to begin to put down your driver diagram. And in fact, it may feel like, gosh, this is a huge project. It's a huge, it's a huge complex system. Where do we start? This driver diagram and developing your driver diagram will really help you to see that and help you to really focus on where it is you want to spend your time and actually what the priority is for the changes that you want to test. Thinking about that aim and that project goal, we're going to come on and share with you the overall programme driver diagram, and it will help you to identify your measures. So actually a well-written aim, is it specific? Can we measure it? Is it achievable? Important to think about all of those aspects. So the next slide, again, talking about primary drivers, and again, we'll come on to thinking about how we develop the driver diagram, but these are the big topics, the big things that you'll need to work on in order to achieve your aim. Areas of the system that you'll need to influence within your project. So capturing these within your your drivers, and also having that well-written primary driver will help you to start thinking about some of those process measures. We'll just go through the next couple of slides, I think, quickly, Claire, because then we'll actually get to talking about the development of the driver diagram. Okay, so secondary drivers, again, the things that would need to be in place to positively influence that primary driver, and that you might need to involve other people in understanding this. So going back to that, really important point about it's a whole team activity. Thinking about the difference between these primary and secondary drivers. So if the driver is a really big and critical issue, then you need to be seeing that as your possible primary driver. And again, thinking about your secondary drivers, they will help you to develop your change ideas. And interestingly, I don't know if we've got anybody on the line with us from Cornwall, but Louise has very kindly shared her driver diagram from Cornwall team. And within the secondary drivers, Louise has then identified some change ideas, really very practical then change ideas to support the implementation of that overall project aim. So we go on to the next slide. Okay, change ideas. As I said, these key components. The ideas that your team would like to test in order to move you towards that overall aim and project goal. And again, thinking about your change ideas, and I think, again, lots and lots of ideas out there about how we can expect to, to achieve our aim, but by association, they are all expected to achieve the aim. I know that sounds obvious, but it's just thinking again about what it is, where we're trying to get to. So if we think about the driver diagram with the project aim on the left-hand side and on the very far right-hand side, your change ideas. Your change ideas are your actions, and they are leading towards the effect, which is to achieve that overall aim on the left-hand side. And so everything lines up in terms of supporting and working towards that overall aim. And if you think about those changes that you want to test, those are the things that you're going to then take forward using your plan, do, study, act cycles. So again, if we're thinking about the relationship to the model for improvement, we're asking that question, what is it we're trying to accomplish, which is our overall aim? What are the changes that we can make that can lead us to that? And actually these change ideas being those ideas that we want to test using the plan, do, study, act cycles. We spent quite a bit of time talking about prioritising change ideas. Susanna talked about some different methods, talked about also thinking about how do you identify which out of your change ideas would have the biggest impact, which things, if you like, are focusing on a particular part of the system that are enabling you to work within the team, your team environment, things that are within your control, and also the things that actually you're going to have to work on at a system-wide level. And that's where we've talked about the importance of aligning with your overall trust improvement plan. And that as part of this project, you may only be working on one change idea in the context of urgent and emergency care and short stay wards, and particularly improving the care for the person who may be in their last 90 days of life. So actually a very focused piece of work. And again, when you start to look at your driver diagram, you may have associated change ideas, but actually they may be focusing on a much bigger part of the system. So they're important to capture and not to lose, but as you start to prioritise what you're going to focus on for this project, it's important to ask yourself these questions. So I think we can move on to the next slide. So creating the driver diagram. Okay, so we've talked about the importance of the project aim goal. So brainstorm potential drivers. You can start with that, concentrating on generating ideas for these drivers and not necessarily, worrying too much about, well, okay, is this primary, is this secondary? Just get all those things out on the table with your team. And then you can start to cluster those ideas. And importantly, when you're starting to think about these drivers, think about, actually, is it going to improve? Is it going to decrease? Because obviously what we want to be able to do is to identify measures. And the more these drivers are really clear and are really sort of focused, then actually that can help you to start to do that. And then you can start to think about the links between these primary and secondary drivers and the actions or interventions for each driver. And then focusing on the measures that you want to identify. Okay, so we're going through this very quickly, but we're going to get to a short presentation shortly from Don Goldman. And again, I hope that will give us a very good summary about driver diagrams. It gives you your plan on a page. It gives you where are you going. There is no right or wrong driver diagram. And in fact, our program driver diagrams changed at least twice. Yes. It's about your team's understanding of the system you're trying to improve. Where is it you're trying to have impact? Undoubtedly, it will change as you get more understanding about your systems and your processes, where you're trying to make that change happen. And importantly, that it aligns to your measurement framework. And that everybody understands what you're trying to do and how they can contribute towards achieving it. So it also gives you a really good communication tool. We try to kind of do this practically, don't we, in our team meetings, Claire? We often get the driver diagram up. We say, well, you know, are we still on track with this? Does it make sense? Do we want to change something? So, you know, I think my tip is that you just keep this a live document, and it's not a right or a wrong. So the next slide brings us on just to some resources, and again, these resources are widely accessible out there, and we are going to, all being well, I don't know, we may need Amber's help for this next section, but we're going to watch the clip off YouTube of the Don Goldman presentation from the Institute for Healthcare Improvement. And Don is a Chief Medical Scientific Officer at the Institute for Healthcare Improvement. And also he's very much an expert in infectious diseases, and he uses that example in this YouTube clip. So I think Amber has got this. We probably need to come out of this presentation and just bear with us. We'll just see if we can find this now on the slide. Oh, okay, so now it looks like we've got action. Thank you, Claire. Seamlessly we went into the video, and I'm hoping you can hear it.
One of the biggest problems I see in quality improvement in general is that folks run off to do their PDSA cycles, and then we find out that the cycles and the tests have been done on things that don't matter that much for what they want to accomplish. So I'm assuming that you're coming to this session today with a specific aim in mind. There's some measurable outcome that you want to achieve. And the question is, where do you begin? So the way I would like to help you begin is to think about the pathway between your ideas for change, the evidence-based practices, the innovations that you think are important. What's the relationship between them and the outcome you want to achieve? I call this the causal pathway. It's really cause and effect. You have some level of belief that if you do certain things, you will advance your measurable outcome, things will improve. So a driver diagram is a simple, visual, somewhat intuitive display to help you understand where you're going with your work, and also to help others understand what you need then to do to help you. So let's think about something simple. As you know, I like to talk about myself. This seems to be a problem that I have. Maybe I should work on PDSA cycles on that. But today I'm going to talk about losing weight. So I think if you're looking at me, you're probably saying, well, he's a pretty fit guy for someone his age. But actually, I'm a little disappointed in the way my body is shaping up. And I could easily stand to lose 5 to 10 pounds. And that's a measurable aim. Let's say 5 pounds. That's a modest and achievable aim, should be. What are the key drivers? What are those major, highly leveraged things that I need to do to lose that 5 pounds? So let's talk first about the primary drivers, those things that are kind of at the very heart of the matter. As far as I know, there are only 2 major drivers for me losing weight. One is calories in, the other is calories out. So those are my primary drivers. There are only 2. When you set up your project or have your own personal work you want to do, you may have 3, 4, even 5 drivers. But if you're getting to be 6, 7, or 8, or 9 drivers, you're just not getting it down to the level you need to be simple and actionable. So calories in, calories out. Now, what things can I do to reduce my calories in? Well, that sounds relatively simple. I can, for example, cut down on sugary soda drinks and measure how many Cokes or whatever it is I have during a week as an effort to improve my caloric intake. So right away you see that in any driver diagram, the changes have to be measurable. How am I going to know that I'm actually improving? So in the case of sugary drinks, it may be I go from 5 a week to 2 a week, and I'm going to measure that. I'm going to do my tests of change around that. In terms of another change I might make, this is stressful work. I mean, talking to you, I got a certain level of stress, although I love doing it. And at the end of the day, I do like to go home, and with my dinner, I'll have a glass of wine. Well, I don't know if you know this, but a glass of wine is 150 to 200 calories. That's an extra 150 to 200 calories in measurable calories that I'd like to cut down. So maybe I'll say on the weekends it's not so stressful, I won't have my glass of wine, and right away there's 300 calories fewer in. Now, The other thing you want to think about is driver diagrams are pretty simple. They're linear, and you can see that on the illustration that you're seeing now. But sometimes it's a little more complex. So drinking that glass of wine has an effect on calories out. Well, how can that be? Well, I should be going to the gym. That's part of my calories out part of the driver diagram. I should go several times a week. I promise you, I've had a glass of wine, my 180 calories in, I'm not going to the gym. So there's 400 calories that aren't coming out. So that's kind of how a driver diagram works. And you can get very specific about the kinds of changes you want to make that you believe will result in the improved outcome and how you're going to measure it. So I hope that's clear, because now I'd like to move us on to a healthcare example. So I'm an infectious disease guy. I don't know if I've told you that in previous lessons, but that's what I do. So I worry about things like MRSA, or methicillin-resistant Staph aureus, and we're going to go through a driver diagram for how we can measurably reduce colonization and infection with MRSA. So similar to what I just told you about losing weight, there are only two major drivers for reducing MRSA. One is a driver to reduce spread and colonization. The other is the driver to reduce actual infection if you should become colonized. Those are the two major drivers that you see here. And arrayed behind them are what we call secondary drivers, or you can think of these as major, highly leveraged changes that are going to help you accomplish these aims. So obviously things like screening patients for methicillin-resistant Staph aureus might be important to help you control the spread, or certainly careful hand hygiene, wearing gowns and gloves, keeping your precautions routines highly reliable. That's all going to help you reduce spread of the organism and therefore reduce the chance of infection. But let's say you now have a patient who's colonized, you still want to reduce the risk of infection. That's where, for example, the bundles for CLABSIs that we discussed last time comes in. If you are fastidious about your care of those central venous catheters, then the chance that patient will get an infection with MRSA, even if they're colonized, are drastically reduced. The same for ventilator-associated pneumonia bundles. So those are your drivers to reduce infections. And behind those to the right on this particular demonstration, there are even more specific changes, ideas that you think are evidence-based that will help you achieve your goal. That's really all there is to it. I'll just say that be sure that whatever you want to change, whatever idea you have, is measurable, that you can actually do PDSAs and measure your improvement.
And it's a really useful short video presented by Don Goldman from the Institute for Healthcare Improvement, and just really summarises some of what we were just talking about earlier on around the use of driver diagrams in helping us with our quality improvement. And I'm really pleased we've got Julia on the call today, and also our colleagues in Cornwall, who have been very again shared with us your driver diagrams, and so I think hopefully starting to see how these can be valuable in getting that sort of plan on a page about the focus for your improvement projects. So I mean, I think, Claire, because the next part of my presentation really was just talking about preparation for the 20th of June event, would it be helpful for colleagues in Shrewsbury to present, and then we can maybe do that towards the end, so that we give an opportunity for time on today's call?
That sounds fantastic. So, Debbie and colleagues, can I hand over to you in Shrewsbury to present your findings so far?
Yeah, that's great. It's Ellen here, Ellen Roddy, one of the consultants. So,
hello, Ellen. Sorry about I wasn't quite sure who was going to lead.
Yeah, no, I haven't sent slides or anything like that, but I'm just going to give a brief summary. I won't really talk about the Fresh Eyes walkthrough,
No, that's fine.
but I'll talk about the case file review, which is almost complete. We have struggled to identify cases in a short time frame, in the 0 to 3 days. So we have a few more sets of notes that are coming to us from the audit department. But we've looked at all of the day 4 to 28 through those themes, and then maybe when I stop talking, people can ask questions at the end, if that's okay.
That's great.
So the themes from the case note review really show that in some cases there's been active treatment, including treatment in intensive care, where the patient was identified as uncertain recovery, and that some of those treatments have been inappropriate or over intensive. We've seen that delaying the important conversations leads to a delay in preferred place of care, but also about 1 to 2 days average of inappropriate treatment. So even if the conversations are had on ANU instead of in the ED, it kind of pushes the whole admission, delays the whole admission, if you like, by 1 to 2 days. We have found that a third of patients had admissions in the previous 90 days before their final admission, which means that there are some lost opportunities there for planning. And we also found that in the situations where the outcome had been a relatively good death, there have been some planning in place. So communicating that planning, for example, community DNR forms or advanced plans, was very, very variable. So there was no formal way of making sure that that information was passed from setting to setting. And in fact, in one set of case notes, I found an envelope that had been filed, hole punched through, still sealed, that contained all of the advanced care plans, and it hadn't been opened at all because nobody knew it was there. So there are some themes that are going to guide us in terms of interventions. I think we can all see the need to develop better communication between settings. And I think we're thinking about something that we've resisted for a long time, which is having somebody on ANU who is specifically tasked with having these important conversations and allowing consultants in some situations to delegate that. We've always previously felt it was really important they did it themselves, but actually it's not happening. So we're going to look at a model where that might be done by our frailty team, for example. So yeah, I think there will be more learning once we've looked at the short stay patients, because I think that the ED interactions will be more important in those patients, but that's where we're at the moment. So that's the end of my presentation.
Thank you very much, Erin. That's really interesting. I don't know if anybody's got any questions or comments from the other sites. Stunned everybody into silence.
Everyone's stunned. I should say that the case reviews have been carried out by 2 of us. So Emma Corbett, my colleague, who's a palliative care consultant, and then myself as a general physician. So we've kind of got 2 aspects, if you like, looking at things from a palliative care and also the acute take point of view. So that's been very useful.
So what were the big surprises for you, or what were things that reinforced it for you?
I don't know, Emma, were there any? I think I was surprised in one particular case that there was a patient, a renal patient, who was already well known to the community palliative care teams and had been identified as conservative renal care. And even when all of those stars lined up, they still ended up having inappropriate treatment, still ended up coming into hospital. So there's something around not just making sure that the patient's in contact with the relevant team, but making sure that those plans are then enacted and that people think about where those plans might go wrong. There's no good having a plan in place if people then fall through the gaps. So I think that was a bit of a surprise to me, that it's possible to be involved with all the right agencies and still fall through the gaps. End.
So it's Anita speaking. I think that's it's really helpful to hear your feedback, and also, you know, that actually that I think is a really really great example where the driver diagram can help in a sense of seeing the connections between systems, because actually what you're identifying is, you know, is the gap there, and actually that's not necessarily because somebody didn't know, as you said, you know, this person was well known, but it's also that sense of, if you like, where sometimes the responsibility is for that action actually happening in the system. So you know, so I think it's a really great example, I think, where the driver diagram, and I'm not sure again where, you know, where you came in on the session, but actually I'll put the program driver diagram up just next after this, Claire, because I think that just gives a really good example, and again, I hope that through looking at it through different sort of sets of eyes, really, and different expertise, has really sort of helped to surface actually these are the priorities for action, because it felt really clear from what you were saying there around the recognition of uncertain recovery, around the importance of conversations, you know, that missed opportunity for planning, and then actually the complexity of making that happen in a system when you've got, you know, different teams working on different aspects of care. So I think fantastic you've also, you know, been able to do the case file review, because I know when we came to Shrewsbury it was, you know, that was something that you know, were very much working on, but actually getting the time practically to sit down and do that is, you know, it's tricky, isn't it, fitting that in with everything, but hopefully also a really great activity to sort of really focus you know, your thinking around what you already know are priorities.
Yeah, I think I was pleasantly surprised by the recognition of uncertainty in the vast majority of patients who died.
Yeah.
There really was only one patient where it seemed to come as a surprise to the clinical team. So I had thought that we would be worse than that, but actually there is a lot of good documentation around recognition of uncertainty. I think the other thing that surprised me was that having daily senior review wasn't necessarily a good thing when it came to those conversations, in that sometimes people were lulled into a false sense of security, I think, by daily senior review, particularly if the, you know, consultant reviewing wasn't taking on those decisions and that uncertainty. So I think there's something around, rather than focusing on the grade of the person who's doing the review, it's the skills of the person who's doing the review. That's very important.
That's really, really helpful, and I think it's, Julia, I know, has had to leave us. She's had to go to clinic, Julia Grant in Leicester, but I know that Julia's been using a training needs analysis, hasn't she, which is something that she might share with us on the 20th of June, which,
brilliant.
You know, again, in terms of skills, because that's really important. I think the other thing is about the case file review is it's also there to shine a light on really good practice, and I think again feeding that back to teams and to clinical team staff is really important to know what we're doing well, isn't it, and reinforce that and say, actually, you know, we've looked at these case files, do you know what, we're doing okay with this, we're really doing well, and you know, and again I think that really positive feedback that can come from this process is really as important as understanding what we need to do, isn't it?
Absolutely. So have you had thoughts about where you're going to focus following your case file review?
We're not quite there yet, really. I think we need to look at the drivers and the training needs.
Yeah.
I mean, for me, there's something around AMU kind of directing the whole process. It's the crossroads where the path is set. I think ED, there are some tweaks that we can make, but actually looking at patients who've come through the ED, I think that uncertainty is being recognised, and often the DNR forms are being filled in and the conversations had. So, I mean, I don't think that ED have as much to do as we thought they might. So for me, it's AMU. It's going to be AMU, I think, but it's early days. So
yeah. No, it's great just to home it down, because you could do so many things, can't you, with what you've sort of said, but it's trying to home it down and say which ones are going to focus, which bit you're going to focus on, so that you can make that difference and not spread yourself too thinly. Anita, can I ask you to talk about the driver diagram?
If I can go on to the next slide, and again, just not sure quite where people came into the presentation today, but this is the overall program driver diagram that that we have sort of again developed really as a team, and so there will be a lot that's very familiar here, and there will be a lot which I'm sure will be, you know, aligned with your thinking as well from case file review. But thinking about our overall goal, which is about improving patient care and experience and outcomes for patients who may be in their last 90 days of life. So actually, you know, that's our overall outcome. And then if we sort of work across there in terms of our primary drivers and our secondary drivers, you know, you can see there again in the primary drivers those big areas around recognition, around early on attendance and admission, around clinical teams having conversations and you know, again delivering care in line with those professional standards and what's important to the patient, and also again, you know, that driver there about care plans and conversations being available and alerted to their existence. So I think, you know, your example there, Ellen, of the envelope with advanced care plans that actually hadn't been opened is just, you know, it's key, isn't it? And again, in terms of effecting that change and that happening, you know, it's something that is a system-wide. It's a system-wide driver. It's quite a big thing, isn't it, for us to get that working well. And clearly the environment, you know, and that being flexible to support compassionate care, particularly as we know in a very busy ward, you know, ward environment, very busy AMU, ED and hospital environment. And again, we know with the Fresh Eyes walkthrough, we saw some really great examples of how teams were providing that compassionate care, and also, you know, again, open conversations about some of the challenges of doing that and how, you know, what things we might address to improve that and changes we can make. So those are our primary drivers, and then our secondary drivers there, you know, thinking more about our systems and processes and how they support us to achieve that. So, you know, again, we've got our focus there around those prompts, those clinical systems that prompt recognition, team working, communications handover, you know, our rapid onward transfers of care and conversations. And again, we just spoken about highlighting conversations and where they're happening. Communication, again, around previous admissions and contacts. A good patient flow, really important. Having side rooms, you know, we talked a lot about privacy and availability of quiet rooms and side rooms for conversations. So, you know, some of those, again, drivers in the system. And then thinking about the change ideas. So what is it we want to do differently to try and make a move towards that overall aim? And again, there's so many things that we could do. As Claire's just rightly said, what is it that actually you specifically want to test? You know, the ideas that you have as changes. And I think we think about improvement. You know, it's about how we put, you know, knowledge into practice, isn't it? So, you know, you may be thinking, well, actually, we would like to implement a tool for early recognition, and, you know, you'll be looking at something that's been tried and tested and validated and used in different areas, but you'll be applying it in your local context. So, you know, your test of change will throw up different experiences, and it's about how you can adopt that and adapt and work with, you know, it in the system in your own environment. So that's the learning that will come from this. And then you know, we haven't listed all the ideas for change. What we don't want to do is to you know, kind of jump to any solutions that you might want to put in place, but importantly that you can think round from your case file review. And as you said, you know, just now, you haven't quite decided yet where your focus is because you're still really assimilating all this data. And I think, you know, putting it down in this way then allows you to ask those questions. Well, where are we going to get most impact? If it's in AMU, actually, okay, so what's the test of change we want to put in place? And also, how do we know that that's going to be improvements? So thinking about measures. And again, we've got some measures there. I think, you know, when we've been talking to you, you've been telling us that actually the outcome measure that you'd be looking for and that you'll be seeing in those case files is that record, that documentation of what's important to the patient, and actually, you know, have we met that? And in many cases, you're saying, well, actually, not even seeing that recorded at this stage. So, you know, is that an important measure? Process measures, and again, we've just put that process measure up there around recognition at risk of dying and likely to die. So, you know, we'll be seeing those process measures. And interestingly, the balancing measure we've put there is this perception of time spent in the first 24 hours, because certainly with our learning from the previous cohort of trusts that took part in this programme, we had a really good example of that, where the team introduced a new process in the ED departments in the first 24 hours, I think at AMU as well, and exactly actually it was AMU when they tested this change. And what they found was that it was taking a lot more time of the senior doctor involved at that point in time. So, of course, what that generated was that sort of sense of, well, actually, it's going to take too much time, therefore we can't do this, we can't roll this out wider. But actually, when they started to look at this, it was about a perception of time spent, and actually, yes, it was a longer time in practice, but actually where it saved time elsewhere in the system, and the knock-on effect was a much more effective handover, and actually what it enabled them to then start to think about was how to roll it out, because the consultant working on the care of the elderly ward said, well, actually, when we receive someone that you have had this conversation with and you've taken forward this planning, it becomes a much more effective plan of care and transfer of care from an AMU to a ward environment. So I think, balancing measures, where is the impact? What is the impact on the system? And if you like, the unintended consequence. So also thinking about things that, may result from your tests of change, and understanding actually those positive and, if you like, inverted commas, potential negative impacts. And then thinking about actually, okay then, so how do we refocus that test of change? What might we do next time? So I hope that's helpful, Claire. And I think just moving on to the next slides, okay, so the next series of slides are really what we would like to invite you to prepare for when we come to meet on the 20th of June face-to-face for our next community practice event. And there should be, and I hope, are no surprises in the next series of slides here, but we'll just go through them quickly, because it is about saying, what is your, thinking about your case file review, thinking about your learning. So what is your overall aim? And, again, you can see here, we're not being prescriptive about the template. You might already have one that you're using. You may have started to develop a driver diagram. I know that some teams have and have already shared them with us. You may decide you want to just have a quick brainstorm and put it on Post-it notes, and that's absolutely fine as well. But it's also, that tip about don't forget your measures. How are you going to know what tests you put in place that made a difference? And keep it as simple as possible. We get very complicated very quickly, don't we? I know I can do the world's worst at that. So keep it simple. That's what Claire's always telling me to do. So the next slide. Again, this is the template you can use if you wish to. And if you write in this, these boxes will just expand, and then you can move along your arrows and make something, as you just saw with the program driver diagram. So if you haven't got a template and you wish to use this one, please do. If you prefer the Excel template, then the one that's on the NHS Improvement Hub, we will share the link to, and it's equally a great template that you can use. So as we said earlier, for consistency, think about your objective, your primary drivers, secondary drivers, change ideas, and measures. And that's the kind of common elements that we want to, just to give some thought to, not to come with a finished product necessarily, although if you have your working model, absolutely fine, but just to come with some preparation, because this is what we'll do a lot of work on in teams on the day to help to get to that next stage of change ideas. Okay, so that's the results from the case file review, and the next one is the results from the Fresh Eyes report, and then the next one, if you are at this stage, I know not everybody is, but if you are at this stage and you've got this idea and you think, actually, is this going to make a difference? Then the best way to just kind of touch and feel it is to just take forward this PDSA, get into this thing about, actually, okay, so I've got this idea, let's plan this test, let's do it, and let's see what happens, and let's also see what your next actions are, and just test that in a very controlled way. So, you might say, well, actually, we're going to do this, we're going to just introduce this and just test this with one consultant working with 1 or 2 patients, and that is just, the way that you can get to this next stage of testing some of your ideas. And then I think that last slide, I think there's, yeah. So we put forward a poster for the IHI conference, is what I want to say, the international conference in February, which Dr. Vincent Connolly was there presenting, and the poster we shared with IHI was talking all about the previous work we'd done with the other 4 trusts, but it was also updated a little bit from emerging themes that we are starting to talk about here, because this is all developing work. I think the next slide has got a copy of that poster. So what we would like to do is build on this learning, because you've already started to share with us your case file review headlines. And so what we'd like you to do, if it's possible, is just to share those bullet points with us so that we can develop this poster and again share back with you a collective picture across the community practice on the 20th of June. So again, really just the headlines, any key findings that you're prepared to share with us. I think, Amber, you've circulated the poster in a PDF format, haven't you? But again, just starting to understand this across the system. And I think, again, Ellen, you were talking there about your findings about lost opportunities, and a third of your patients having had an admission to hospital prior to the one that you were looking at here in the case file. So, just starting to see this data as well, I think, in a much more whole systems way, about how it's working, is really surfacing important information that we want to build on and share. So I think that's the last slide, Claire, in terms of the slide set, that just kind of brings us on to any questions, really.
Just open up, has anybody got any questions about what Anita's presented or anything generally? What we were going to do was sending all this information out to you either today or tomorrow, so that you've got all the templates if you need them, if you've not already started to develop your driver diagram. So do I take a silence that everybody's happy?
Yeah. Good.
I don't need to think of something else to think about to get you to do.
I think the other thing that I would say is that our colleagues in NHS Improvement, who you are connected with at regional level, we know are very experienced in developing driver diagrams, as many of you will be on the call as well. But just, there is lots of support and help there if it's something that you want to access that, and we'll make sure we send out, as I say, some useful practical resources just about getting this sort of down to the next stage, really.
And we've also recorded sessions, so if you did miss any of the beginning, or with people dropping in and out, we've recorded it so you can sort of listen at your leisure if you like to, so that you can sort of pick up anything that you might have missed. Thank you very much indeed. So we look forward to seeing you all on the 20th. Marie and Paul up until the end of May will be in touch, but the rest of us are here, and you've got Amber, who's part of our team, who will be the point of contact as well. So thank you very much for presenting today, Erin, and it's been really, really great. And we look forward to seeing you all on the 20th. Thank you very much indeed.
Thank you. Bye.
Bye.
Bye. Bye.